welcome to everybody from the Zambia end of the team. And I'm, for those who haven't met before, I'm Jill Swallow. I'm one of the haematology consultants. I'm based in Nottingham in the UK. And this is a presentation about diagnosis and management of thrombosis in pregnancy. Just before I start, there is we are very much open to suggestions for topics going forward for this monthly meeting, and we have had a few suggestions already. But if you have got difficult cases that you come across from an obstetric haematology perspective, if you have topics that you would like to be covered, then please do get in touch. Orton and I email with regards to the programme, so please let him know if there's anything that you'd like to bring or anything that you'd like to cover. So what I'm going to cover today, as I say, is the diagnosis and management of thrombosis in pregnancy. I have got a separate session that I tend to do about non-pregnant patients, but I just intended to cover the pregnancy aspects today. So let me just get rid of this so I can see better. There we go. So what's the risk? Well, we know that VTE is increased during pregnancy and in the postpartum period. And the VTE incidence is quoted as DVT being 1 in 1,000 and PE being 1 in 250,000. But antenatally, that's much higher than the baseline risk in the non-pregnant population. We know that postnatally, the baseline it's 60 times the baseline risk compared to the non-pregnant patients. It's much higher in the postpartum period, and that risk persists for around about 3 months after pregnancy. Thankfully, the case fatality rate is rare. Approximately 1%, less than 1% of pulmonary emboli are fatal. But that's really when we talk about thromboprophylaxis and we talk about management in pregnancy. That's what we're really trying to prevent. It's important to say that VT risk starts in the first trimester. So when it's indicated, we start prophylactic anticoagulation early. What I'm going to present is a very idealized view of how we diagnose and manage VTE. But I think everything that I say, everything that we talk about has to be borne in mind depending on what resources are available in your particular centre. So this is some UK data, and one of the things that we do in the UK is we collect data routinely on maternal death, and every 3 years, every triennia, there's a report published which looks at why women die in pregnancy. And VT is really important because it remains, certainly within the UK population, one of the leading causes of direct maternal death. And that's really been consistent in terms of its incidence across the last four triennia. So it's really important reason why women don't survive pregnancy, albeit maternal death remains rare. So why do pregnant women get VTE? Well, this is Virchow in the top right-hand corner, who was often called the father of pathology, the father of thrombosis, and he described a triad that we talk about a lot. We talk about the circumstances that lead to an increased propensity to clot. And during pregnancy, women are hypercoagulable. Everything that makes you clot sort of goes up, and protein S, part of the anti-clotting pathway, goes down. And the way I describe this when I'm teaching is that this is physiological. I think it's nature's way of preventing excessive, or trying to prevent excessive blood loss at the time of birth, because we know women bleed when they have a baby. So increased von Willebrand factor, clotting factors, and fibrinogen with a reduced protein S. You've then got stasis. Part of this is that the fetal head compresses the iliac veins, so it's obstructing venous outflow. And if you scan women in pregnancy, you can see that the flow through the iliac veins is often quite sluggish. You add into that the fact that pregnant women, particularly towards the end of pregnancy, are less mobile. In the postnatal period, depending on the type of birth they've had, they can also be less mobile. There's also endothelial damage from turbulent placental blood flow, and all of these things were described in Virchow's triad as contributing to thrombotic risk. So it's not hard to see why women have more of a risk of thrombosis during pregnancy than when they're not pregnant. So one of the things, this is sort of taking a step back really from the diagnosis and management of VT. It's really thinking about how do we assess risk, because VT prevention is highly important. Now, all of these things on the diagram here on your left are all risk factors for thrombosis. So as well as the factors I've described, there are lots of other things that will increase a woman's likelihood of getting a clot in pregnancy. Has she had a clot before? Is there a family history of thrombosis? We know that sickle cell disease is a prothrombotic condition and therefore the risk of thrombosis in pregnancy is increased. These are all intrinsic risk factors to an individual. And then you add in the labour and the delivery risk factors, preeclampsia, preterm labour, placenta previa, abruption section. They're all risk factors for having a blood clot. So one of the things that we do in the UK is we use the RCOG guidelines, which were published in 2015 and undergoing review at the moment. And these are called reducing the risk of venous thrombosis during pregnancy. And what they do is they assign a score to risk factors, and they split them into pre-existing risk factors, obstetric risk factors, and transient risk factors. So, for example, if you've had a clot before, that gives you a score of 4. If it was provoked by a major surgery, it scores a 3. And you can see down the list, there's the different risk factors that are given a score based on the relative risk of thrombosis. Then you have some obstetric risk factors. So you can see multiple pregnancies, cesarean and labour. All of these are known to increase the chances of a woman having a thrombosis. And then there are transient risk factors. So these are the ones that come and go. So, for example, hyperemesis, obstetric OHSS might only be a problem in the first trimester. Infection, admission to hospital, immobility, dehydration, these are all transient risk factors. So it's important that that risk assessment that we undertake is reviewed when women's clinical situation changes. So what we do is all women have a risk assessment at the beginning of pregnancy, and that's usually when they book with their midwife, which tends to be around about 10 weeks gestation. They're assigned a score, and then depending on the risk of that, the outcome of that score depends on what happens. I'm just trying to see if there's another slide here. This is probably the better slide to show you. If a woman scores 4 or more, we would routinely offer thromboprophylaxis from the first trimester and all the way through pregnancy. If a woman scores 3, we would offer that for 28 weeks. And if we scores 2 or more, they get it postnatally, but not no thromboprophylaxis, chemical thromboprophylaxis I'm talking about here, antenatally. And what that recognises is that as pregnancy progresses, the risk of thrombosis goes up. So if you remember that diagram back on the first page, we know that from 28 weeks onwards, there is a slight increase in the risk of thrombosis and the highest risk postnatally. So you don't need to score quite as much at those time points to qualify for an offer of thromboprophylaxis. If we admit anyone to hospital, we recognise admission to hospital as a risk factor. They would be offered thromboprophylaxis with low molecular weight assuming that they weren't bleeding or giving birth, or prolonged admissions within the puerperium. And we use enoxaparin in our centre, which is a low molecular weight heparin, and I've just for reference put some of the dosing information down there. So what we do, as I say, we do a risk assessment at booking. It's repeated at 28 weeks, and it's repeated at the time of birth when the woman has delivered her baby immediately after that. We also reassess it if anybody's admitted it early with hyperemesis and seen on our early pregnancy units, admitted to hospital. And it's really looking for those women who we can prevent thrombosis from happening. There are a couple of other indications where people historically have used thromboprophylaxis. Recurrent miscarriage was one of them, but there was a big study published a couple of years back now, the ALIFE trial, which looked at inherited thrombophilia and recurrent miscarriages, and it wasn't shown to be benefit, so it's not given routinely for that reason. Antiphospholipid antibodies. If you've got antiphospholipid syndrome, we give obstetric antiphospholipid syndrome, we would give prophylactic low molecular heparin along with aspirin for patients in that situation. So really, this is thinking about how do we prevent thrombosis from happening. But of course, we can't prevent all thrombosis from happening. And many of the women who are diagnosed with a VTE in pregnancy actually have a score of 0 or 1. They don't have a lot of identifiable risk factors. But diagnosis of VT in pregnancy is difficult because many of the scoring systems, the clinical scoring systems that we would use, are not validated in pregnancy. For example, the Wells score, which is probably one of the most widely used risk assessment scores in the UK, isn't validated for pregnant patients. The risk is also, as I've described, different to the average non-pregnant patient. There's something called the left score, which has 3 parameters: left leg, edema, and first trimester. The D-dimer, again, this is something that it would be used as a negative predictor for in the non-pregnant population. So if you have somebody with a low risk, a low clinical risk of VTE, of DVT, sorry, and a normal D-dimer, then that's a negative predictor of DVT. But because the D-dimer's increased in pregnancy, it's not validated. And there was a couple of studies that were published a couple of years ago. One was the DIPEP study, and that looked at a wide variety of different clinical decision scores and biomarkers in suspected PE, including the D-dimer, but all of them were found to be unreliable in pregnancy. But the difficult thing is on the flip side is that, yes, diagnosis is difficult, but a failure to identify a VTE can be life-threatening, and particularly if it embolizes to PE. And I think that what that has led to is a very liberal use, certainly within our services, a liberal use of CTPA, but with a very low prevalence of PE in those investigated. And certainly in our centre, probably less than 2% of scans that we perform would be positive for PE. So the first step really, though, is the clinical signs or symptoms. So leg pain or discomfort, swelling. In pregnancy, it's much more common that it's the left leg that's affected. Often with high up DVT, so iliofemoral DVT, it can often be sort of lower abdominal or a very severe groin pain. PE presents similarly to the non-pregnant patient, prolactic chest pain, shortness of breath, hemoptysis, tachycardia, collapse. But it's also important to remember that not all shortness of breath in pregnancy is PE. And so therefore, if you have a pregnant patient who is short of breath and the PE is excluded, you still need to go back and think, well, why is she short of breath? Is there any other reason why that might be, and not simply stop at that point? There was something called the pregnancy adapted years algorithm that was it was published around about the same time as the DIPEP study back in 2019. And what this looked at was women who were pregnant with suspected PE, and a D-dimer was undertaken and an assessment of the presence of 3 years criteria, which were clinical signs of DVT, hemoptysis, or PE as the most likely diagnosis. And then if you follow the flow chart through, it basically gave an indication of what to do. And this was like I said, published in the New England Journal of Medicine, and it's worth taking a look at. And it said if there were no years criteria with a low D-dimer, then PE was ruled out, and it was safe to withhold anticoagulant treatment. But then, as I say, I won't read it all out for you because it will take too much time. There were no missed pulmonary embolisms by using this algorithm, although there was one DVT out of 477 patients missed, which was one of the criticisms of the study. This was slightly difficult because it gave a slightly different outcome to the DIPEP study, which suggested that the D-dimer wasn't useful. So in terms of the diagnostic options for VTE in pregnancy, I'll just go through some of them. The first would be straightforward DVT scan for DVT and ultrasound scan. So the pros are that it's non-invasive, it doesn't involve radiation, and it's the first line test if the symptoms of DVT. The cons are that a PE obviously can occur without DVT, and particularly in the pregnant patient, you can't often image the pelvic veins, so above sort of the iliac veins and above, it can be quite difficult to see because of the gravid uterus, but it's certainly the first line test that we would do. A chest x-ray, when women come in with shortness of breath, it's a low dose of radiation. It can't exclude PE or diagnose DVT, but if somebody's short of breath, it might provide an alternative diagnosis for that shortness of breath. D-dimer we've talked about, and it's a simple blood test, but there's some validation, but it's limited or conflicting data, and false positives will occur in pregnancy. It might be useful in combination with other information, but certainly I wouldn't rely on a D-dimer in the pregnant patient to exclude VT if there's clinical suspicion. MRI you can do. The pros are there's no ionizing radiation, and non-contrast can identify DVT missed an ultrasound scan. So if you've got a lady who you're suspecting PE, but the ultrasound is negative, particularly if you're worried about high up DVT, MRI can be used. I would say that we very rarely use this. It's exceptional that we have to use MRI scanning to make a diagnosis. Occasionally, maybe one or two patients, the odd patient a year, we'll see where we need to do an MRI scan. And there is some controversy about the use of gadolinium when scanning pregnant patients. When we're diagnosing PE, we can use either a CTPA or a VQ scanning, and the choice really will depend on what you have available at the time. Often we find that VQ scanning, certainly within our centres, is less available because of the lack of isotope. The CTPA has some benefits in that it might provide an alternative diagnosis, and you can use reduced radiation techniques. But the cons are that there's a slightly higher dose of radiation to the maternal breast. There's a theoretical increased risk of childhood malignancy, and I think that a lot has been made of this over the previous years. And I think this is one thing that often you'll find worries women. And I think it's really important to counsel them that the amount of radiation that the fetus, I've put the numbers there, and I've just compared that to a transcontinental flight, for example, of 0.03 0.035 as compared to the radiation to the fetus. And I think I'm often asked to go and see women who are really concerned about having any imaging in pregnancy, as is understandable. Women are very concerned about the safety of their baby, and I think my approach really is that it's actually far more, if you've got a very significant clinical suspicion of a PE, it's far more important from the safety of the mother and the pregnancy and the baby to actually have diagnostic imaging that confirms or refutes a blood clot, because if you can't make a diagnosis, you have to then continue with therapeutic anticoagulation up to the time of delivery, and it does impact on birth choices and risk around the time of birth. Um, that was a bit about diagnosis. And again, as I say, I think it depends a little bit on what's available in your centre. I think the other key bits to think about in diagnosis, particularly of DVT, is if you have a woman in whom we've seen cases here where the woman has a very swollen leg, but the ultrasound scan is negative. And I think it's really important to have that clinical input at that stage and say, actually, we're not going to stop the anticoagulation. And I have often carried on anticoagulation in this scenario because of the limitations of ultrasound scan. Sometimes we have the possibility of doing a slightly more detailed ultrasound scan. We have a vascular lab again in our centre who will scan women to see if they can see clot higher up. But I think it's important to acknowledge some of the limitations of the tests that we use and not simply think, well, the ultrasound's negative, I'm going to stop their anticoagulation. We sometimes do have to continue until we're either comfortable that it's excluded, or if we can't exclude it, the safer thing will be to treat as if there has been a clot there. When we talk about treatment, we use low molecular weight heparins routinely. They don't cross the placenta, and there's extensive observational safety data. We can use donepezil for patients who've had HIT before. One of the things we sometimes come across, and it's important to acknowledge, is that heparins are of porcine origin. So from a religious perspective, some not just pregnant patients, but some patients are not comfortable using low molecular weight heparins. One of the ways we've approached this locally is to seek advice from the local imams, and we do this regularly and update this advice regularly for our patients. And certainly locally, the imams are very happy and comfortable for heparins to be used in this scenario because it's medical treatment. However, there are still some women who would prefer not to have medication of porcine origin. And for those women in pregnancy, fondaparinux is an option because that's synthetic. It's not of porcine origin. There's less data on fondaparinux in pregnancy, and it does cross the placenta, but it's felt to be likely to be safe. I think the one difference and one difficulty with fondaparinux is it has a much longer half-life, and therefore when you're talking about omitting it for the time of birth, or particularly if you're wanting to use regional anaesthetics, that has to be borne in mind that it will take longer to clear. Other anticoagulation can be used in pregnancy in very specific situations. It does cross the placenta, and it's known has known teratogenicity in early pregnancy. But there are some circumstances whereby warfarin is used under consideration and in discussion with a patient. So examples of this would be mechanical heart valves. No, not all patients, and there's a really good BSH guideline for the use of for the management of women with mechanical valves in pregnancy that is very much worth reading. So some of the higher risk women are sometimes treated with warfarin during pregnancy. I've also had experience of cases where, despite low molecular heparin, women have continued to thrombose and required warfarin. But I've only really seen that, I think, once in the time that I've been looking after pregnant patients. DOACs, apixaban, rivaroxaban cross the placenta, and there's an unknown risk. So therefore, currently, they're not recommended during pregnancy. I've just put some of the dosing there. There are a variety of low molecular weight heparins available. Historically, we've always used the twice daily dose, particularly of nadoparin and enoxaparin. I'll talk about enoxaparin because that's what we use in our centre. We've used twice daily enoxaparin due to the accelerated renal clearance of low molecular heparin pregnancy and the larger volume of distribution. But actually, there's a lack of evidence to support that really, and there's certainly some pharmacological data that shows that that the trough level is similar whether you use it once a day or a higher dose twice a day. So I think if you have patients who and certainly the ASH guidelines will also advocate the use of once daily or offer that as an option. So I think if you have patients in whom access to medication is difficult or compliance is difficult, then I think with shared decision making, using once daily it's going to be better than inconsistent use. What we tend to do initially in our centre is diagnosis of VT is to use the twice daily dose additionally for the first 3 months and then go down to a once daily dose. Because I think also when you come to the time of birth, it's a little bit easier to facilitate a window for delivery in that situation. I'm often asked about whether you monitor low molecular heparin levels. Now, you can monitor low molecular heparin with anti-10A levels, but for most women, this isn't indicated. I would personally do it for somebody who has antithrombin deficiency because low molecular weight heparin, the way it works is to potentiate the action of antithrombin, and if you have low antithrombin, you need more. Extremes of weight, it can be done renal dysfunction. I don't tend to do it very often in that situation. We sometimes do it if somebody's had a recurrent VT on anticoagulation. And certainly, again, although this is outside the scope of this talk, with mechanical heart valves, we would always need to do anti-10A level monitoring to ensure that those levels are sufficient to protect that woman and her valve as much as possible. So low molecular heparin in pregnancy in terms of safety, there is an increased risk of bleeding peripartum. I mean, I would say anecdotally, we tend to see very little problems bleeding antenatally. Certainly, what I tend to say to patients is that on its own, low molecular heparin isn't going to make you bleed. But if you bleed for other reasons, so for example, pregnancy-related reasons, it will make it worse potentially. So therefore, if you have any bleeding in pregnancy, you need to stop it and be seen before you carry on again. Minor skin reactions are quite common. We often find that switching to a different agent can help. It's often the diluent rather than the drug itself that women are allergic to. So we start with enoxaparin. If a woman has a problem, we would give her dolteparin. It still has a problem. I've had a couple of patients who've had problems with both, would have tinzaparin, but serious reactions are rare. There's a negligible risk of osteoporosis if low molecular heparin is used exclusively in pregnancy. Unfractionated heparin has a greater impact on bone density loss, but both these, it's with longer term use. You don't tend to see a problem for women in pregnancy. And heparin-induced thrombocytopenia is exceedingly rare. I've never seen a case in pregnancy, and the absolute risk is very, very low. So you don't need to monitor the platelet count unless a woman's had prior exposure to unfractionated heparin. We reduce the dose in renal impairment, but importantly, low molecular heparin is safe in breastfeeding. A little bit of low molecular heparin does get into the breast milk, but it's denatured by the acid in the stomach, so it's not clinically relevant to those babies. So we do say to our women that it is safe to take when you're breastfeeding. Similar with warfarin, you can use warfarin in the breastfeeding patient. I know it's quite common for patients here to be told they can't, but certainly warfarin and enoxaparin, you can breastfeed with both of those. I just wanted to talk a little bit, I think we've got a bit of time, about the management of birth and this is particularly for women who are taking the therapeutic doses of anticoagulation because they've had a diagnosis of VT during pregnancy. And really, the timing of birth, it has to be quite individualized because it depends a little bit on when the thrombosis happened and what's the thrombotic risk for that individual. And so, for example, if you have a lady who's had a thrombosis at 10 weeks gestation, you're going to be far less worried about stopping her anticoagulation as compared to somebody who has a clot at, say, 37, 38 weeks, who's had a very small amount of treatment to try and reduce that thrombosis burden. So what we tend to do is have a discussion with the woman along with the obstetricians as well, because you also need to factor in what are the obstetric indication. Is the lady diabetic? Does she have a diagnosis of sickle? When do her other um, obstetric considerations depict when she needs to give birth? And we work the low molecular weight heparin plans around that. But women should stop the heparin if they think low molecular weight heparin if they think they're in labour. And for planned birth, we aim to stop it 24 hours beforehand. It takes about 24 hours for that for the therapeutic dose of enoxaparin to be out of the system in somebody with normal renal function. Conversely, if people are on prophylactic enoxaparin, then that window is sort of 12 hours before you, and we tend to use those thresholds for regional anaesthetic. So if a woman's on prophylactic enoxaparin or dolteparin, waiting 12 hours before citing a regional anaesthetic. If they're on therapeutic, 24 hours before it's possible to cite a regional anaesthetic. And we tend to ask, we have obstetric anaesthetists who come to our clinic and will meet with women antenatally who are taking therapeutic doses of enoxaparin to discuss their pain relief options and to really just talk to them about what happens if you can't have an epidural, say, and you need an operative birth, for example. Talking a little bit about general anaesthetics in that scenario. So as I say, for planned birth, we tend to stop low molecular heparin 24 hours before. Some women prefer to have more control over their anticoagulation at the time of birth. So, for example, we do offer women an induction if they would prefer that, to be able to time stopping the enoxaparin, particularly if they're very keen to have regional anaesthetic. Now, again, there are pros and cons of that approach because, particularly first time mothers, we don't know how long it will take to get them into labour. They could actually end up off anticoagulation for much longer, having an induced delivery as opposed to a spontaneous birth. So whilst you would increase your likelihood of having a regional anaesthetic, you would make it more likely that the enoxaparin or the heparin's out of your system at the time of birth. Conversely, you might slightly increase the thrombotic risk, which we know is significant around the time of birth. So again, it's all there's a lot of discussion that goes on around when women deliver when they're on the therapeutic doses. When they come in labour, we tend to check their blood count. We do a clotting screen and a full a group and save on admission. I think the clotting screen is less of a concern, and I know that's something that you don't necessarily have access to. And I'm not sure it adds an awful lot because you would expect a clotting screen to be normal for somebody on therapeutic low molecular heparin. It doesn't affect the basic coagulation screen. But certainly having a group and save with blood available if needs be, and obviously IV access in labour. We monitor carefully for excessive bleeding, and again, a bit of that depends on how long it is since they had their last dose of enoxaparin. Tranexamic acid can be used. There's a lot of concern about historic concern, I think, about tranexamic acid being prothrombotic, but certainly it can be used where it's clinically indicated, even if women have had a VT before. There's a lot of data from the woman study in particular that didn't show an increased risk of thrombosis with tranexamic acid. Would encourage women to mobilise in labour, keep them hydrated, and to give them some compression stockings to reduce the VT risk. For operative births, I think there's a few considerations because these are women who are on therapeutic doses of anticoagulation, and the aim is to put them back onto therapeutic anticoagulation post-operatively. So I say consider wound drains, but it's not mandatory, and I'm not saying that everyone would need that, but it's considerations whether or not that will be indicated, and careful hemostasis at the time of operation. Consider pressure dressings, and really just thinking about anything you can do to minimize ooze or bleeding postnatally, because one of the things that is of concern, particularly when you're putting women back onto therapeutic doses of anticoagulation, is a wound hematoma, because that causes an awful lot more problems for the woman, an increased risk of infection. They're often off anticoagulation for much longer. And it's really, they're much more tricky to, a nasty wound hematoma is much more tricky to manage for women who are anticoagulated. I've already alluded to this a little bit about a timed versus a spontaneous risk. And as I've said, it might improve access to regional anaesthesia, but it does increase medicalisation. It might increase the need for intervention. And you can always have to plan for a spontaneous labour. Even if a woman's planning to have an induction, she may go into labour beforehand. But I think VT in pregnancy, it isn't an indication for a C-section as a risk factor alone. Just because you've had a VT in pregnancy doesn't mean that you necessarily have to have a cesarean section, particularly because we know that operative births increase the risk of thrombosis. So it's important to have shared decision making with the patient. And I think for the vast majority of people on prophylactic dose low molecular heparin that are waiting spontaneous labour is the right thing to do. And then having that discussion for the women on the higher doses. IV unfractionated heparin, it's very rarely used nowadays unless there's a very high risk. I can't remember the last time I used IV unfractionated heparin. It's very difficult to get right. You need access to clotting screens, and I know again that's something that's not necessarily available, and it's not something we would regularly use either way here. We mentioned neuroaxial anaesthesia and making the anaesthetic teams aware of these women when they come in labour. The windows we use for enoxaparin, low molecular heparin, will be 12 hours after a prophylactic dose, and therapeutic dose 24 hours. Intermediate dose, we have a few patients who are on intermediate dose low molecular heparin for various reasons. Intermediate dose, we tend to people call it different things, but I would tend to say a double prophylaxis dose. So prophylaxis, for example, 40 milligrams once daily, and intermediate will be 40 milligrams twice a day or 80 milligrams once a day. But there's no good data on how long you should wait after intermediate dose low molecular heparin. So we tend to talk to the anaesthetists about these women, but there's very few women that fall into this category. And then it's important to make sure that you wait the specific amount of time after use of a spinal or epidural to give the next dose of low molecular heparin. And as well, making sure that the epidural, if that catheter has been sited, it shouldn't be removed within 12 hours of the most recent injection of prophylactic low molecular heparin, that is. So it's making sure that you get the timings right in discussion with the anaesthetists. Postnatal management. So, as I said before, these women need to go back onto anticoagulation if they've had a venous thrombosis during pregnancy. And bearing that in mind, it's what can we do to reduce the risk of postnatal bleeding? So, for example, early repair of vaginal trauma. We've mentioned close attention to hemostasis at operation. You've got women who are very high risk of hemorrhage, and it does occur. We give them mechanical thromboprophylaxis initially. We do sometimes consider unfractionated heparin, but as I've already said, very, very rarely use this. And we restart low molecular heparin as soon as it's safe. And I think it's really a risk assessment in this situation. If you have somebody who's very high risk of hemorrhage, you sometimes have to accept that it isn't safe to start low molecular, it isn't safe to start any kind of anticoagulation medication. And it's balancing up that risk and keeping them under regular review and restarting when it's safe to do so. So what I tend to do in my practice, obviously this won't apply to every single woman, is to look at how much postnatal blood loss has been. Is there any ongoing blood loss? Is there any ongoing risk factor for hemorrhage? Any concern from an obstetric perspective? If not, I would start a prophylactic dose of low molecular heparin between 4 and 6 hours after the woman's given birth. And then I tend to titrate the enoxaparin. And I give a BD prophylactic dose for the next 48 hours, so 4 doses, and then treatment dose from the next day. Now, like I say, it's important to note that one size will never fit all. So you have some women who have had a vaginal birth who are much higher risk of thrombosis, who might need to start therapeutic a little bit sooner. And the key thing is really keeping the women under assessment. These are not the type of women who are going to come in, have their baby in the morning and go home in the evening, because you need to make sure that they're safe and that they're safely transitioned back onto their therapeutic anticoagulation in the postnatal period. And then in terms of duration of anticoagulation, so for we split when we talk about thrombosis in general, we tend to try and divide thrombosis up into provoked or unprovoked events. So provoked events simply meaning that there's an identifiable risk factor that has, and in the context of pregnancy, that risk factor has now gone. So for a new VT in pregnancy or the postnatal period, we give between 3 and 6 months treatment. Generally, 3 months is a standard treatment duration for somebody with a significantly provoked thrombosis where that risk has gone. But because obviously these VT may occur early on in pregnancy, you have to treat all the way through pregnancy. And we always would give a minimum of 6 weeks postnatally because that's the highest risk time for women having a thrombosis. I tend to review patients at 6 weeks, and I think that's a good opportunity to talk to them as well about advice for the future. Things like if you've had a clot in pregnancy, there is a chance of recurrence in any future pregnancy. So we would advocate or advise those women to have prophylactic anticoagulation in subsequent pregnancies, ideally started at the time they become aware that they're pregnant, purely as prevention. I would talk to them about hormonal treatment, so hormonal contraception. We would advise avoiding any estrogen containing contraception in favor of using progesterone based preparations, which have a lower thrombotic risk. So it's really talking to them about risk. I also talk to them about signs and symptoms of venous thrombosis in the future, even outside of pregnancy, and what to do should these occur. I talked to them about post-thrombotic syndrome. A combination of symptoms that can occur in patients who've had thrombosis before. And those patients who are previously on we do have some patients who are already on long-term anticoagulation. We need to transition them back onto long-term anticoagulation after their pregnancy. So it's a good opportunity, I think, at that 6-week appointment. Yes, we want to talk to them about what's happened during the pregnancy, but also giving advice for the future and making sure that they know what to do in the future in terms of thrombotic risk. I've touched a little bit already on this about breastfeeding, and I mentioned warfarin, low molecular heparin already in an earlier slide. DOACs at the moment, they're not licensed. Well, nothing's licensed in breastfeeding, but they're not licensed. And there is limited safety data and experience because they are much newer agents. We, the general consensus at the moment is that they're unlikely to be harmful, but there's just not quite enough data out there yet. We know that rivaroxaban and dabigatran levels in breast milk are far less than you would use if you were anticoagulating an infant, because we know, rivaroxaban, for example, is licensed for the use of treatment of thrombosis, even in very young babies. We know that the levels you'll find in breast milk are much less than that. But apixaban concentration higher and the drug's untested, so we'll definitely avoid that. But I think there's more data to come on DOACs in breastfeeding, in the future. So I think I've got a couple of cases just to share. I think we're okay for time. So this is a 25-year-old lady who she was previously fit and well. And at 25 weeks gestation, she was admitted to the emergency department with very acute shortness of breath. She was very unwell when she came in. She was cyanosed and tachycardic, very low SATs, very low blood pressure. This is a young, fit woman, so to drop her blood pressure to that level, it's quite significant. A chest X-ray was normal, but a bedside echo was done, which showed a significantly dilated right ventricle. So I'm aware that the internet link's probably not sufficient to be able to answer this question. I'm not sure we would manage it to be too interactive, but I think, thinking about what you would do at this stage. I don't know if anyone can chat. Can anyone speak? Oh, hello. Yeah, I'm not sure how possible it's going to be to chat these through, but essentially the question is, what would you do at this stage? This is somebody who is very unwell, and the working diagnosis is a pulmonary embolism. And so the way we manage PE outside, I think whenever you're managing anything in pregnancy, I think you have to think as a baseline, well, what would I do if this person wasn't pregnant? What can I not do because she's pregnant? And what could we do instead is sort of a very generalized way of thinking about it. But the way that we classify PE, or the way we treat PE or make treatment decisions in PE, is based on early mortality risk. And this is taken from the European Society of Cardiology 2019 guidelines on the diagnosis and management of PE. And what it does is it splits individuals. This is not specific to pregnant patients at all. This is any patient with PE, and it splits them into high, intermediate low, or low risk based on their early mortality risk, based on these parameters here. So just to run through the top line, for example, if you've got hemodynamic instability, clinical parameters, so they use something called a PESI score or this PESI score. If there's right ventricular dysfunction on echo or CTPA or relative cardiac troponin level, so that would fall, you would fall into a high risk score. That's for that particular patient. And certainly one of the things that is used to look at whether patients, again, outside of pregnancy, should be thrombolyzed, it's these patients in the top category here that have benefit from thrombolysis, with less evidence for those in the intermediate high and intermediate low risk. Just circle that there. So again, this is taken from the same guideline, the management strategy in acute PE. If you have somebody who has higher risk, is falling into that top category there, you would want to look at reperfusion treatment and hemodynamic support. For those falling into the intermediate risk categories, intermediate high risk, you keep a really close eye on these patients. They should be managed in an HDU type setting where if they deteriorate, you then have the ability to consider rescue reperfusion, so moving into the high risk management protocol. The intermediate low risk will be hospitalised, and then the ones at the lower end of the risk score can sometimes be early discharge home on treatment. So this is what you do. This is what will be done for the non-pregnant patient. And the reason I wanted to mention this case was because thrombolysis in pregnancy is something that isn't often done. There's actually an ongoing study at the moment that we're part of looking. It's a retrospective study looking at decision making around thrombolysis. But there are some patients, such as the one I described, in whom actually thrombolysis is the right course of action. And this was something that was published in 2020, a systematic review. You can see there's really small numbers of patients, 43 of them antenatally and 11 of them postnatally. And as you can imagine, the major concern here is going to be bleeding. 18% of them, of the women had major bleeding, but none of it was intracranial. There was one maternal death due to refractory cardiogenic shock, and 8 out of 43 fetal mortality. So the risks are not insignificant. Postnatally, there were 9 major bleeding events, but most of those were uterine bleeding. But overall, the data, and this data and previous data, doesn't suggest that there's a prohibitive risk associated with thrombolysis for PE in pregnancy. And certainly, it's something that we would always consider in a woman in whom it was clinically indicated. It's important not to withhold treatment that could potentially be life-saving in this situation, because you have to save the life of the mother in order to be able to save the life of the baby. There's no known teratogenetic effects of thrombolytic agents, and theoretically, they don't cross the placenta, because drugs with a molecular weight of greater than 1,000 cross poorly into the placenta. And you can see just from the list there that these are higher than that which would be expected to cross into the placenta. And this is our NUH guidelines here. And let's say it's a bit small, you might not be able to see it, but the principles of thrombolysis are the same. But there is obviously shared decision making within the team. This isn't a decision that somebody would make alone. It's important that the right people are involved in the discussion. So we often will have an obstetrician involved, or we should have an obstetrician involved, a haematologist sometimes, a respiratory clinician. And this is the flow chart that we use. I won't go through it in detail because it is quite detailed. So this lady, we thrombolysed her with alteplase, but she did deteriorate during the thrombolysis, deteriorated further. The discussion was had regarding intubation and ventilation. We even discussed something called ECMO, which is available in a local centre nearby to us, extracorporeal membrane oxygenation. But she actually stabilised and was transferred to the intensive care unit, and she was initially treated with IV unfractionated heparin. And on CTPA, which was done after the thrombolysis, this was done on clinical grounds. She had bilateral PE in both main pulmonary arteries, extending into all lobar arteries, and there were signs of heart strain. So you can often see straightening of the intraventricular septum on a CTPA, which shows that the heart's strained. But 24 hours later, she had considerable improvement. She switched to enoxaparin, and an echo was done on day 3, which was completely normal as compared to the dilated right ventricle she'd had when she first came in. There was some concern that she'd been quite hypoxic for quite some time, and a fetal MRI was done to have a look and see if there was any evidence of ischemic brain injury, but there was nothing evident on the scan. It's not. It will be. It's a poor. I think it would be a poorly diagnostic test, but it was done to look and see if there's any evidence of that. And the outcome was that she had an induced labour at 38 weeks. She'd had enoxaparin for just over 3 months at that point and had an uncomplicated birth and no adverse outcome in the baby to date. So I just wanted to share that as, an example of somebody where thrombolysis was the right decision. And I remember the obstetricians talking to me about this lady and saying that she was peri-arrest at that point, and had they done nothing, I think the outcome would have been very different. This is another case. So this is a 34-year-old lady who was 38 and 6 weeks pregnant, and she'd had 2 previous spontaneous vaginal births at term. She presented with sudden onset shortness of breath and chest pain, and the clinical suspicion was of PE. So she was commenced on 1 mg/kg of enoxaparin. The lower limb Doppler showed bilateral thrombus in the distal common femoral veins, and a VQ scan was high probability PE. Now, what I would say actually is, and I probably should have said this when we were talking about the diagnostic side of things, is that the majority of PE will start as DVT. So if you only have access to one form of imaging and somebody's come in with a suspected PE, actually having an ultrasound scan is useful, because if there's clot there, you can make a clinical diagnosis of PE. If there's not clot there in the lower limbs, you can't exclude a PE, but actually it might preclude the need for having chest imaging, particularly if that's not something that's easily available. So this lady, she'd had a PE and bilateral DVT, and her echo was normal, but she had no signs of labour at that stage. And again, this was meant to be slightly more interactive, but I guess thinking about what you would do now, have a quick minute just to read through those things and see what you would do. So if people can put, I don't know if you can put your hands up on here, and I can tell you what we did. So the considerations here are that she's very close to the time of birth. She's had 2 spontaneous vaginal births before. I tend to ask women when they've delivered before, because I think I'm always a bit more worried about somebody who's had births earlier on, particularly when we're talking about managing VT towards the end of pregnancy. Oh, sorry, my computer's just frozen. There we go. So we continued enoxaparin, and we discussed some of the delivery options. And we discussed with interventional radiology about putting an IVC filter in at that stage. But IVC filters in pregnancy, and again, I just wanted to mention this because these are questions we're often asked. And there's not an awful lot of data, and there's no randomized controlled trials for the use of filters in pregnancy. And the indications in general for IVZ filters would be if you've had a recent thrombosis and an absolute contraindication to anticoagulation, which I guess for a woman coming in this situation who she's not labouring at the moment, if she was in labour, that would be an indication. The older BSH guidelines, which are old now, said to consider if there's a contraindication and extensive VT shortly before delivery. And they quote within 2 weeks. RCOG, which is the updated version in 2015, said to consider using IVC filters if you've got an iliac DVT, so high up DVT, or if you've got patients who've got proven DVT and recurrent PE despite adequate anticoagulation. And this is a paper I've just referenced here from Journal of Vascular Interventional Radiology, which again is quite old now. And they looked at 124 patients with IVC filters cited in pregnancy. They had no fatal PE, a small rate of PE after filter insertion, but no fetal morbidity or mortality. There was 1 maternal death due to air embolism, no sepsis, but just over 10% of women was a failure to retrieve the IVC filter, which is one of the real worries about putting IVC filters in is the I think you might not be able to remove them, and if you can't take them out, then that woman would need some form of anticoagulation, like in all likelihood in the long term. And then, sorry, that's just a very long list of things that can happen with IVC filters. I'll have a quick read, I won't go through all of them. So what happened next? This case was interesting because she had a baseline clotting screen which showed that her APT was slightly prolonged. She didn't have a bleeding history, so that's the first thing we would do, take a bleeding history. But we did have some factor levels done which showed her factor 11 was slightly on the low side, only just slightly low, but there was a bit of concern about this at the time of her birth because we were anticoagulating her. Also, the fact that there was discussion around whether to use IV unfractionated heparin around the time of birth for this lady, but that relies on APTT monitoring. We monitor it as a ratio compared to, and her baseline APTT wasn't normal, so it was going to be difficult to manage IV unfractionated heparin. So for the time being, we carried on with the low molecular weight heparin. However, the next day, so this is the day after she had been diagnosed, she was labouring and the baby was breech and she needed an urgent cesarean section. She'd had her last dose of enoxaparin 12 hours previously, and this was a therapeutic dose. She was a high BMI, she had a recent PE, she was high risk GA, and the anaesthetist wanted to do a spinal. So, only going back to what I'd said, we'd normally wait 24 hours before putting in a regional anaesthetic. So I guess the question is, again, what would you do now? So have a read of those, just have a think of what you might do in that situation. And then I can tell you what we did with her. So we didn't think that she had particularly significant bleeding risk from her low factor 11. It was very mildly low and she had no bleeding history. So we waited as long as possible. And she had a cesarean section under spinal. It was 18 hours after her last enoxaparin dose. It was uncomplicated and she had a litre of blood loss. She was very, very briefly on IV unfractionated heparin, but then we switched her back to enoxaparin, 1 milligram per kilogram twice a day in the postnatal period. She actually had the IVC filter in, as you remember from the previous slide. But unfortunately, the attempts to remove this IVC filter failed, and she remains anticoagulated in the long term. And her subsequent factor 11 levels were completely normal. So again, this is a lady, and particularly when the filters don't come out, you look back and you think, was it the right thing to do? But I think this lady had a significant thrombotic burden in her lower limbs, as well as already existing pulmonary embolism, and laboured very quickly after diagnosis. So I think it's about balancing up the risks of doing nothing versus the risks of intervening, and it can be difficult. I think I might stop there because we're going to run out of time otherwise for any questions, because it's just past. So let me just stop that. So quite a whip through there in terms of diagnosis and management. Are there any questions that people wanted to bring up? Anything about the talk? Just feel free to shout out. I can't necessarily see everybody on the screen. I suppose I've got a question for you at your end. How often would you see VTE in pregnancy within your service? How common is it? Don't know if anyone wants to answer.
We have some patients who come through with VTEs, but unfortunately, sometimes it's the issue of confirming the diagnosis. So for those that have lower limb DVTs and others, we are able to do the scans. But for the CTPA, most of the times it's challenging to get the results in good time. So sometimes, especially if it's a massive PE, you might the risk of losing a patient before the diagnosis is made is usually very high. Then considering the years, the modified years criteria in pregnancy. In a setting like ours, where especially rural areas of Zambia, where it's not easily possible to do the CTPA or the perfusion, ventilation perfusion scans, would you recommend that we use it, especially if the criteria is satisfied, the D dimers and the risk of VTE if they are satisfied, and we start treatment based on that? Because we don't, especially in rural areas, we rarely have those investigations.
I was going to say, but the pregnancy after years use the D dimer as part of its criteria, and I'm presuming that do you have access? How easy is it to get a D dimer?
The D dimers are easier because we have a number of labs that are dotted around the country that either send the samples to Lusaka, where they can easily process the results, or others they actually process in the outskirts. So the D dimers would be easier to do, and they're actually cheaper to perform.
Yeah. And I think actually it can be very useful in that setting to actually looking at the number of the patients that you don't need to image if you based on what's available in your local centre. So certainly I think that's a reasonable approach if you depending on what you have access to. How easily do you have access to ultrasound scanning?
Yes, we have, but the challenge again with ultrasound scanning is that I think most facilities now have, but some facilities it's only a few people that are able to perform the Doppler scans. So in that regard, if that person is not around, means that you have to wait for that person to be present for that scan. But for the university teaching hospital, it's easier to get a Doppler scan at any time.
Yeah, and I think actually, you know, it's that one of the important things is that you start the treatment at the point of suspicion. You don't wait for the diagnostic imaging, like any patient with a DVT or PE as a suspicion. You would always start treatment, so you have got a little bit of flexibility in terms of time. And obviously, you don't want to wait a month before scanning somebody because then, you know, the risk is that you've decreased the clot burden sufficiently so you don't see anything. But certainly, actually, there's leeway in terms of timing as long as you start treating the patient